Good afternoon or good morning, everybody. Welcome to NCSD's It's Your Call. Our topic this month is rapid syphilis testing and STD programs, challenges and opportunities. We're really excited to be promoting this topic. We had a lot of interest. We had over 111 people register for the program, and we have over 60 people on the line right now. So I think there's a lot of interest in this topic. My name is Charlie Ravens. I'm a technical assistant consultant with NCSD, and I'm going to be one of the call facilitators along with my colleague, Sarah Stahlberg, who's our adolescent sexual health coordinator. NCSD, for the last couple of years, has been sponsoring these It's Your Calls to really promote learning from STD programs from each other. There's a lot of great stuff happening in STD programs at the state and local level, and there's no reason why we can't really share a lot of the tools that we all develop with each other, so we don't have to really what we call recreate the wheel. So those of you who've been on these calls before, you see this is one of my favorite comics about, you know, why recreate the wheel when there's so much really good stuff we can learn from each other. So that's kind of what we're trying to promote through this series of calls. A couple of housekeeping items. It's really important that you keep your phones on mute, listen only, or keep them muted. Because we have so many people on the call, it's really not possible to have questions and answers right during the call. But at the end of the call, we hope to be able to open it up and have some questions. But during the call, you will be able to ask questions, and I'll tell you about that in a second. If for some reason I lose internet connection, Sarah, our backup staff, will be able to keep the call going until I can get back on. We are recording the call, and we will make this recording, both video and audio, available both on the NCSD website as well as on NPIN, and as well as any of the presentations and tools we talk about. If you do have questions and comments, we're going to try to allow for 3 to 5 minutes after each speaker for questions, and there's a chat box on the left side of your screen. Just write your question there, and if you can indicate, we'll try to answer those at that time, or we'll save those for the end if we have a lot of questions. So first of all, we always like to get a quick read of who's on the call. So if you could just take a second and let us know where you primarily work. Is it a local health department, state health department, CDC, et cetera? So just choose one. And it looks like almost 90% of our, 85-90% of our participants today are from state and local health departments, which is great. That's who we're really trying to reach. As well as our colleagues at CDC and others. But again, these are calls for people working in programs. So in thinking about this, session, we really wanted to come up with present information that you would work in a program would really want to know. And so we've asked all the speakers to sort of address a series of questions, such as why and when did you implement rapid syphilis testing? What have been some of the opportunities and challenges that you encountered in planning it? Which populations and venues did you test in? What testing outcomes and metrics have resulted from rapid syphilis testing? And we've talked to a lot of people. Some people have had a lot of success. Some people have had some challenges. And so, we really wanted to mix it up and get a good mix of people. We want to know what type of staff people are using to conduct the test, and especially what role, if any, have DIS played. What have been the program costs, not only in regard to the test kits, but also staffing and other things? What policy and training materials and tools that you've developed can you share with other programs so they don't have to, again, recreate the wheel? And what are the lessons you've learned from rapid syphilis testing that would be helpful for other programs? So I think we have some great speakers today. I'm doing the introduction, followed by Bill Smith, who's going to give some comments and perspective from NCSD. And NCSD was very active in helping get the FDA to approve a rapid syphilis test. From Pennsylvania, we're going to have people from Pennsylvania, Texas, and Virginia kind of give us their experience. And then at the end, and we are going to extend this a little bit longer if we need to have more questions and answers if we don't get those answered after each speaker. So before I turn it over, Bill, I want to let you know a couple of tools that are available. World Health Organization has a really helpful tool called the use of rapid syphilis test. It's got, they've been doing rapid syphilis testing for at least 10 years, and there's a lot of good information in this document. Again, we will make the slides available, and you can link to this or just search for WHO use of rapid syphilis test. Is a really good tool. On the NCSD website, we've actually created a web page for resources on rapid syphilis testing where we are asking programs to give us a copy of their testing protocol so that it's very helpful when somebody's developing a protocol if they can kind of borrow what somebody else has done and then adapt it for their jurisdiction. You can really save a lot of time in developing that. As well as some other materials, we have sort of a pamphlet on rapid syphilis testing, how to get started, and some information about CLIA waiver tests. And one of the things that we're going to be adding within the next week or so to our website is we're going to ask you to start providing us with other tools in addition to protocols that you've developed. So, for example, Virginia has a workflow and a quality assurance manual. Pennsylvania has a number of tools. This is just one of them, like frequently asked questions. We'll have copies of training presentations. So we're hoping to really build a library around useful tools that will help people implement, maintain, and enhance rapid syphilis testing. And then we hope to expand this with other topics that we do in the future so that, the NCSD website can really be a go-to source for getting tools from your other colleagues. So I want to turn it over to our colleague, Bill Smith, who's going to kind of talk for a couple of minutes about NCSD and rapid syphilis testing. So, Bill?
Thank you, Charlie, and thanks to everyone for being on the call today. I'm going to be very brief. Let me begin just by, again, thanking Charlie for pulling together this capacity building call. I realize this is one of 3 capacity building calls and webinars that we're doing just in the month of February alone. So we hope we're not overwhelming all of you with the technical assistance, but we think some of these topics, particularly this one, are really important and timely, and we're glad to bring it to you and hope it's fitting into your schedule. I also, if you haven't heard, Charlie is part of our technical assistance and health equity promotion team, and we've just recently made a new hire there after Dana Cropper-Williams left us to take on a new opportunity after being with us nearly 12 years. So she's big shoes to fill, but we're really thankful that Jessica Fraser-Williams, who many of you know, who worked in the California program for, I think nearly a dozen years, will be joining us as our new Director of Programs and Partnerships and head of the TAHEP team. So we're really looking forward to continuing to strengthen the work that we're doing and providing technical assistance to you all. And working with you, as Charlie said, to make sure that we're not recreating the wheel and that we're learning from one another. I wanted to make sure that we did a little note on disclosure. So as many of you know, NCSD has been involved early on the rapid syphilis test, including FDA approval for the CLIA waiver and just some general advanced education on how it would work. And we do receive some significant support over the years from Trinity Biotech, who many of you know has the marketing arrangement for public health for the syphilis health check in the United States. So I wanted to make sure that that disclosure was clear. Just by way of brief intros, all of you know that our syphilis rates are truly, in a word, exploding. And you guys see this in your programs every day. And really, I think we're dealing with perhaps at least two different dynamics. The first is a real significant sexual health crisis among gay men, and rates of primary and secondary syphilis really being concentrated among that population. But also, we know all of you are also seeing increases in congenital syphilis cases where you haven't seen any for a decade, and now all of a sudden you've got several on your hands. And those, of course, are a problem in their own right, but they also help underscore that we've got infection going on among females that requires some of our attention as well. As many of you know, and at the Syphilis Summit that CDC held last month, there will be an update or a bit of a summary from the Syphilis Summit in the NCSD Weekly on Friday, so I'll encourage you to check that out so you can get a little bit of a better idea around what happened there, at least NCSD's sort of take on it. But frankly, there was much good thinking there. And I think what was really interesting is out of that good thinking, it underscored that the core functions of public health remain critically important when it comes to dealing with the syphilis epidemics that we're experiencing. So that includes doubling down on female and male condoms to protect sexual health, and public health departments have always been in the lead in that work. Partner services and the innovations in partner services that need to happen to create better outcomes, and again, specifically for gay men. And then increasing our screening efforts. And while we may not have a ton of new tools to deal with the syphilis epidemics we're experiencing, we do have a new screening tool, and that is the CLIA-waived Rapid Syphilis Test Syphilis Health Check. So I will say no more except to say that I'm really proud of the innovation that we continue to see from NCSD member health department programs across the country. The lessons and innovation that happen on the ground in your health departments is always at the very front of the leadership, and we are able to share that with the rest of the country. So as Charlie said, we're not recreating the wheel, but we're really strengthening STD prevention for the 21st century. The last thing I just wanted to say is if you have not seen it, I believe yesterday was released the March edition of Sexually Transmitted Diseases, and there is an excellent commentary in there by our friends Tom Peterman and Yeti Fakil at CDC's Division of STD Prevention that talks about rapid syphilis testing in the U.S., and I would just encourage all of you to read it. And I believe Tom is on the webinar, so Tom, I just want to say thank you, and please pass our thanks along to Yeti for a great piece. With that, I will stop and say that I'm really looking forward to learning from our colleagues today.
Thanks, Bill. Any questions for Bill before we get started with our speakers? If you have any, put them in the chat box while people are thinking of any questions they might have. I'll move to a couple quick poll questions. So first thing we want to know is, does your program currently provide rapid syphilis testing? And so if you're not in a program, you can just put not applicable. So it's yes, no, but we will in the next 6 months, or we don't have any plans to provide it in the future. So take a second to answer the poll question. So this is very encouraging. It looks like half of the program people are on the call. Half of the programs have already started implementing rapid syphilis testing, and about 20% hope to in the next 6 months. So we hope by the next time we do a rapid syphilis testing webinar, we can get it up to 80 or 90%. So I think that's really encouraging that so many people are have already implemented or are thinking of doing it. For those of you that haven't, what are the barriers that your program faces in using a rapid syphilis testing, such as, and you can mark more than one: cost, questions about test performance, CLIA issues about who can do the test, lack of high-risk population or venues in your project, in your program, you need technical assistance. So again, you can mark more than one of these. So it looks like cost is definitely an issue. About half of the people are saying cost. Questions about test performance is definitely an issue, about 30%. Technical assistance, and we're going to be asking about technical assistance later. So, and this is, hopefully this webinar is one way of getting some technical assistance out there, as well as letting you know who is taking the lead in the field and who you can maybe go to get some information. So with that, let me turn it over to our first presenter, Stephen Kowalski from Pennsylvania. Stephen, take it away.
Very good. Thank you, Charlie. So I'm going to start off just a little bit of background data about Pennsylvania. Like every other state in the country, we've seen an upward trend in syphilis. Primary and secondary syphilis, on average, is up 36% since 2013. This is an upward trend that we've seen since 2004. A little bit of male and female is that recently we're seeing an uptick in female cases. This is a trend that we started to see in 2013, and 15 is continuing that. This is a really important slide. This is a significant demographic shift in the state of Pennsylvania. 5 years ago, most of our cases were in that 39 and above age group. Within the last 5 years, we've seen this uptick in cases between 20 and 29 years of age. Right now, in 2015, roughly 46% of our cases are in that key demographic. One thing I want to stress with this key demographic is that 20 to 29 years of age group is non-exclusively MSM. There may be MSM behaviors associated with that population, but they do not self-define themselves as MSM. They may have heterosexual partners. And this is why we're seeing that increase in female cases, is that when you interview those individuals, they may have MSM partners, but they don't exclusively identify as MSM. So what are we doing with the rapid syphilis test in the state of Pennsylvania? First of all, and foremost, is just one tool in a host of many tools that we have to deal with the syphilis outbreak that we have in the state of Pennsylvania. It's not an exclusive tool, but it is one of those many tools. All the syphilis tests, rapid syphilis tests that we're using that are positive, we run a confirmatory test on that. I don't know if all the states are doing that, but every positive that we receive with RST goes ahead and gets a positive confirmatory test. And we use a reverse algorithm at CDD, which is our contract lab in Texas, for that confirmatory test. In addition, when we first rolled out rapid syphilis testing, we were doing serologic withdrawals on everybody that we were using that RST on, just to get some background data on how the test was actually performing. I'm not going to go over this, just to know that we are using a reverse algorithm. All positives use that process to validate that the positive is indeed a positive test. So we're using a phased approach in the state of Pennsylvania. We started using this test in May of 2015 in our gay campgrounds in the Pocono region of the state, as well as a gay men's clinic in northeastern Pennsylvania. It was at that two venues that we were actually getting some background data on how the test actually performed in real-world settings. Every individual that had an RST done also had a serological withdrawal for syphilis. One of the things we were concerned about was the chance for false negatives. The test does lend itself to false positives, but we were also very concerned about false negatives. We did a lot of dual testing, and we found out that although the false positive rate is very high, we did not have any false negatives. In September 2015, we rolled the RST out to two MSM clinics, one in the eastern half of the state and one in the western half of the state. Fast forward now to 2016, we're starting to roll the test out to our high-yield chlamydia and gonorrhea testing sites. These are chlamydia testing sites that have a positivity in excess of 10%. So we're rolling out the RST in that population, and again, to see what kind of results we get in a real-world setting. In addition, we're hoping to roll it out to our DIS, specifically for our partner services. And those are going to be MSM contacts to known cases, contacts to known early syphilis cases that are outside the critical period, and suspects and associates of known early syphilis cases. We are going through the CLIA process, the CLIA waiver process for them. In addition, Pennsylvania is a little bit complicated in the rollout of the test because not only do we need a CLIA waiver, but our Bureau of Laboratories also has to have a waiver as well. So we have to actually apply for two for our field staff to actually do this test in a field setting. And then we hope, based on the performance of the test in our high-yield chlamydia sites, as well as with our DIS, perhaps to roll it out to the STD clinics, but that's still up in the air. One of the things that's really important as we roll this test out is to make sure that we have a treatment paradigm in place or a model. And one thing that's really important is just by testing, if we have nowhere to treat that individual, then we're in a situation that we don't want to be in. So we're really stressing to our providers that are doing this test is that if you identify a positive, think through the process of where do we refer that client for our treatment services. And our goal is to get them back into their medical home. But we're finding out with this population, many clients do not have a medical home. So we're trying to get them back into the testing site. They actually did the test. A lot of our testing sites may not have a medical practitioner available, so then we have to refer to our STD clinics. And currently in the state, Pennsylvania, we have about 82 dedicated STD clinics across the state. And if that doesn't work, in some rare situations, our field staff may be able to deliver therapy. But again, I want to stress that's a very rare situation. Just some data regarding our rapid syphilis test. From May 2015 to November 2015, approximately 698 tests were done. 84% of those were male, 16% were female. We had 29 positives out of that cohort with a 4.1% positivity. All the positives were males, and 52% were confirmed positive with the reverse syphilis algorithm, and 48% tested negative with the RSA. And then 4% we lost to follow because either the blood was not sufficient quantity or had hemolyzed before it had gotten to our contract laboratory. One thing I want to say about the false positives, as time goes along, our providers are getting better at reading the test. There is a lot of confusion with the rapid syphilis test in identifying if there was a line present or not. Oftentimes the line is very faint, and they're calling that positive where it may not actually be a true positive. And I said some of our more experienced providers, we've seen a decrease in the number of false positives. To date, I want to really stress this, is that we have not had any false negative RSTs. That's something we're really concerned about in the state of Pennsylvania. I'm looking forward to hearing other states regarding false negatives. Some of the concerns that we have in first impressions, the implementation of the RST is not as simple as the manufacturer indicated. There's a lot of training, and ongoing training is still an issue. In Pennsylvania, all our rapid syphilis test sites have to have a CLIA waiver as well as our Bureau of Laboratories waiver. There's a lot of paperwork that has to be compiled before a site is authorized to do the test. We are concerned with biological false positives, and I said to date we haven't had any, but it is a concern. The RST can be more costly, about $17.25 versus about $7.25 for the RSA alone. Currently, we have no dual rapid tests available for both syphilis and HIV, which is an issue. Many times our clients are getting 2 finger sticks, one for the rapid syphilis test and one for a rapid HIV test. We're looking forward to when a dual platform test comes available, so there's only 1 finger stick. We have to make modifications to our online reporting system before this RST becomes widely available in the private sector settings. We are concerned about missing cases or under-reporting. So any questions on our implementation of the RST?
So again, if you have any questions, just write them in the chat box on the left bottom half of your screen, and we'll ask them to Stephen. So we'll wait about a minute or two, see if we get any questions. So Stephen, what would you say your biggest barrier has been?
It's getting the CLIA and Bureau of Laboratories waivers for our sites. And then the training. And the training is still a big issue, is that the identification of that line, if it's positive or not, is still an ongoing issue. And I think that's contributing to our high false positive rate.
Yeah, I was going to ask you any suggestions, because I've heard from other people that was their really concern, that they had too many false positives. So what suggestions would you have in regard to training?
We had a meeting with another manufacturer of the ChemBio test, and they identified the reading of the line as a potential for human error, and they're actually going with an optical reader, which I thought was quite remarkable. And we're looking forward to that technology because I think the reading of that line is a big issue, and perhaps if we can identify maybe a high-quality photographic cue cards where they can actually hold it up to the test and say this is a positive versus this is a negative might help our providers. And we're actually working with one of those, our providers that actually have some experience, to perhaps develop one of those cue cards that we can actually hand out as providers do this test out in the field.
Okay, so we've gotten a couple of questions. Are you planning to replace stat RPRs with the RST, and what's the cost difference?
We do not do stat RPRs in this state. Everything is shipped out.
Okay. Next question. If you can get enough blood from one stick, couldn't you collect blood for both tests from the one stick?
Oh, very good question. The answer is technically yes, but from a CLIA and Bureau of Laboratory certification process, the answer is no. We have to follow those manufacturer specifications to the letter.
Okay. And how did you market the testing, and how receptive were MSM to getting the test?
So we're ongoing with that. Initial feedback has been very positive. 2 of our MSM clinic sites, we're doing some retrospective feedback with those, and they much prefer the rapid syphilis test over the standard serological draw for syphilis. They like the timeliness of the results and getting the status, even though it might be indeterminate, quickly.
Okay, well, great questions and, great presentation. We really want to recognize Pennsylvania for all the work. Pennsylvania was really one of the really early adopters, and they've been great about sharing their tools with other people. A lot of people have been calling them and say, what's worked? How have you been doing it? So we really appreciate the work in Pennsylvania. So let's go on to our next presentation, which is going to be rapid syphilis testing in Texas. And our next speaker is going to be Sydney Minnerly. Sydney, take it away.
Hello. Hi, how are y'all doing today? So we wanted to talk to, just like Pennsylvania, Texas has been doing the rapid syphilis health check for quite a bit of time. We decided to go ahead and do it prior to the CLIA waiver, and we decided to do it. Go ahead and go to the next slide. Sorry, Charlie.
Okay. Can you also speak up a little bit?
Okay, let me turn my head. Okay, is that better?
Great.
Okay, great. Sorry, I'm trying to manage 2 different things here. Okay, so we went ahead and decided to go through and find, Texas is a very high morbidity state. We have areas where there is very low access to care and STD clinic services. We have different cities and rural areas that we have to deal with, and we have a long amount of delay in disease confirmation when we're talking about some of our STD clinics. And when they first presented the test to us, they made it relatively inexpensive for us to use when compared to the reverse algorithm that our state lab had decided to go to. So next slide, Charlie. So what we decided to do is in April of 2012, we decided to we identified 4 small local labs that perform stat RPRs in-house and actually had to send specimens out for confirmation testing for the TPPA. And that delay ranged anywhere from 5 to 14 days. One of our clinics actually ran TPPAs in-house, but they were running them, batching them, and running them on Fridays only. So some of this was allowed for us to assist with the clinicians in doing treatment determination on whether or not this was a biological false positive, or if this is something that was identifying a new case of disease. So what we decided is that if the person tested through their clinic services had a reactive stat non-treponemal test, or RPR, and they had no previous treponemal testing history documented, we would process the specimens for treponemal testing as usual, in addition to running the rapid syphilis test. And programs were to alert our central office of any discordant results so that we could talk to our labs about any future issues. Okay, go ahead to the next slide. Okay, so initially we ran 225 tests. They ranged in age from their mid-30s, but the range was about 16 years old to 71 years old. 47% of the population was Hispanic, 21% African American, and 27% were white. 31% were actually co-infected, or 31 total were co-infected with HIV, and 7 of those were actually identified as new infections. And we wanted to collect this because we wanted to see if there was any difference in the response of the rapid syphilis test. All in all, we identified 170 cases in these clinic settings. 27 of them were determined to be primary, 54 of them were secondary, 62 of them were early latent, and 27 of them were determined to be unknown duration. We had 34 biological false positives that were identified, and because of the false results of the rapid syphilis test, we were able to avoid overtreatment and also avoid public health follow-up for those cases. 4 of those were due to pregnancy. We had a 1-to-1, a 1-to-4, a 1-to-8, and a 1-to-16. Overall, we saved about 5.1 days in waiting for a TPPA, and then 82% of the patients that were diagnosed were treated within the same day. Okay, next slide. So through this study, we determined that the syphilis health check would not be a suitable substitute to replace the RPR, but it could be a replacement for treponemal tests in a clinical setting. We also decided that it was not determined to be a replacement for the combination of treponemal and non-treponemal tests. Okay, next slide. The next step that we did, we felt very confident about the results that we were getting from these sites. The laboratorians were very excited about the results that they were collecting and the ease of the test and their confidence in the test. And so we decided that we were going to, once it got CLIA waived, that we were going to roll it out into more of our outreach settings and our partner services programs. So how we did that is we identified programs that did not have easy access to public health follow-up clinics or any other standalone STD clinics. We also have regional health departments that do not have easy access to laboratories, and so they have to send out their specimens to other providers, either the state lab or other laboratories that they've identified for services. And if they can drive 2 hours, run a test, and have fairly good confidence in the results that they were able to obtain, then they would not have to process that specimen, and that individual, as Pennsylvania's experience was, could have their test results in a very short amount of time. We also decided to roll this out in other HIV prevention testing programs that are in higher morbidity areas and serve populations that are more affected by syphilis infections in Texas. Okay, next slide. Okay, so some of the things that we've had from the field is that we want to talk to our providers about what is an appropriate response to a discordant result. What happens when your rapid test out in the field is positive, and then when you send it off for your confirmation testing and your non-treponemal test, what do you do when that test result comes back negative or non-reactive, and how do you explain that to a client? And so we had to do a lot of education with those providers and understanding what the discordant results are and what they could possibly mean. We had to build up their comfort with the accuracy of the test and the validity of the test. And one of my things is that no test is 100% accurate, and this is a screening test. There are times when you may have a false positive. It does not necessarily indicate infection. However, it is a screening test, and you may be able to follow up with future specimen collections. When I talk to the programs who are implementing the test, and these tests are now being implemented by DIS or disease intervention specialists, as well as phlebotomy-trained prevention staff, as well as these labs that are in the smaller STD clinics. The people rank the test as very easy to use, that they're easy to read. The state does buy the tests for these programs at this time, so they've decided that it is priced reasonably, and it generally is. We also have some prevention programs that have found funding through their own processes to actually implement the test on their own without support for the testing. And most of them have general confidence within the test results. And just like Pennsylvania's response from the clients, they like having the test. They like being able to have their test results in a short amount of time, and they are confident in the test results. Next slide, Charlie. So the what we're talking about is the future. What do we want to do for the future? What do we see? Some of the issues or barriers that we've come across is how do you report a point of care test? And this is something that we've had to deal with a rapid HIV test. So we're not very comforted with the fact that we're going to have issues that we need to talk to our providers and our service members about getting this test reported if there is a positive test result. We also have discussions about what does this look like when we're talking about congenital syphilis. Do we implement the sort of test within the emergency departments and during labor and delivery? What do we do with high morbidity areas or populations? Definitely it decreases the number of false positives that you have, but then you also run a higher risk of persons with previous testing history, and so this test may not be as effective since they have previous syphilis history. And then we've also gotten requests from the field for both a combination non-troponemal and troponemal test, either qualitative and or quantitative. Okay, next slide. I think that's it.
So thanks, Sydney. Again, we really appreciate all the work that Texas has done as an early implementer, as well as sharing their tools with us. So if you have any questions, if you would write them in the text chat box. We do have a couple questions already, as well as maybe some questions for Stephen. So Stephen, you might need to address some questions too. So Sydney, was Texas able to use carryover funds to purchase rapid syphilis test kits?
We were able to identify funding through a various number of sources. We have some funding that was available for this testing. So it was not carried forward.
Okay. So this is a question for either you or Stephen. Any feedback from clients on likelihood of positive tests to actually test negative?
So I can answer that from Pennsylvania. Everyone that has a rapid syphilis test positive is counseled that we're doing a follow-up serological draw, and then that test is the actual definitive diagnosis. So we tell them that there's, based on risk and behavior, that they may be positive for syphilis, but that definitive diagnosis is not back until that confirmatory test comes from the laboratory.
Yeah, and
okay.
That's how Texas is handling it as well. So if a person shows up to the testing site, the counselor is asked to talk to them about previous testing history. And if they disclose that they've had previous testing history, positive testing history, then the counselor will go ahead and do a phlebotomy or blood draw to check on their serofast. However, if the person does not report testing history and or we don't have the support of our database systems that have that testing history available, then they will go ahead and run the test. If it's positive, then they'll counsel the patient on follow-up serology.
Now, one thing I want to mention is that in our gay campground setting, when that person had a positive rapid syphilis test, we are treating presumptively in that setting. That's something that I know some states might be a little bit uneasy with or nervous about, but because of the high-risk behaviors, we are treating all positive RSTs in the gay campground settings on site. So that's something a little bit different than other states might be doing.
Have you had any situations where you treated somebody and then they ended up with negative tests?
Yes.
Any issues related to that, or?
No, because of the high-risk behaviors that are going on, multiple sex partners, unprotected sex, there's a lot of issues there. So, but yes, we have, individuals have received treatment and their follow-up serological test for syphilis was negative.
Okay. And this is to both of you. If someone's positive, do you give them a document stating their status that they can give to the doctor for confirmatory testing, or do you automatically just do confirmatory testing right then and there?
We automatically do confirmatory testing right there.
Same with Texas.
Okay. All right. Other questions?
Oh, and just while you're thinking about that, we don't do treatment in the field unless there is a clinician on site, and at that point we might do, based on the clinician's definition or a concern about increased risk, there would not be application of the treatment, preventative treatment, just based on the syphilis health check.
And in Pennsylvania, the gay campgrounds, it's being staffed by a nurse practitioner, which under Pennsylvania law, they can administer treatment under physician's orders.
I'm jealous.
Yeah.
So this is for both of you. Is a rapid syphilis test positive reportable to the health department? And how do you assure that rapid syphilis tests get reported are not false positive that might result in increasing cases?
Well, in Texas, all positive test results are reportable to the health department. Currently, we're working with folks who are in disease management services, so partner services or HIV prevention, who have experience in reporting positive test results for their rapid HIV test, and so it's a little bit easier to monitor and manage. I mean, that's definitely a concern as it becomes more readily available for providers.
So in Pennsylvania, we're pretty much the administration of that test is going to our site. Trinity has assured us is that if they move to the private sector, that they will provide us a list of the private sector practitioners that have the Trinity Biotech test available to them, and we're going to be doing a lot of intensive follow-up. We do have a log. It's actually a clear requirement anytime they do a rapid syphilis test, and we've modified that log to record that positive, and we're asking those providers to fax those logs into us on a monthly basis so we can actually make sure that they're being reported. But at this point, to our knowledge, the private sector is not yet using this test.
Okay, and last question before we move on. Are there any concerns with false positives of syphilis health checks since you're using it as a replacement for treponemal test in some settings, particularly if someone has a low titer with an RPR?
I don't. In Texas, we don't really necessarily have any concerns about that. We have great confidence that even with the lower end titers, the 1-to-1s, 1-to-2s, 1-to-4s, that if the syphilis health check is reactive or positive, then we would go ahead and treat that person as if they were infected, especially in the lab setting where they have access to the stat RPRs. As far as discordant results, so if the rapid syphilis health check was negative or read as negative and the RPR was positive, then sites are instructed to go ahead and run a full panel through one of either the state lab or a commercial lab that they choose to do the traditional TPPA and RPR.
It's pretty much the same situation with Pennsylvania.
Great. So again, thanks, Sydney, for a great presentation and sharing all your resources, with NCFD as well as anybody who's contacted you for help. So our next and final presentation is from Virginia, Ashley Carter. So Ashley, go ahead and take it away.
Sure. All right. So our strategy with implementing the rapid syphilis test was embedding it within our existing HIV testing point of care framework. So that's what I'm going to be speaking about. So I'm not going to spend too much time on this, but our thought process in putting it within our community-based organizations, that was kind of our strategy. In terms of site selection, they don't have any organizational capacity for phlebotomy at present. Whether or not CBOs begin doing phlebotomy as the continued emphasis on fourth-generation testing, it could impact the strategy, but at present, they are only doing point-of-care HIV and now syphilis testing. So they've really been using this test to go out in community settings where testing would otherwise not be available. There is an emphasis on testing MSM, especially young Black MSM, and CBOs have been able to build trust and rapport with those clients over time. They're seen as a reliable source within the community, and we even have a CBO that's serving a transgender population. So the exclusion of clinical sites. When we began implementing the rapid syphilis test at CBOs, I was contacted by several of our local health departments inquiring about also receiving those test kits. I think conceptually our question was lacking any other indication for presumptive treatment, such as symptom history or a known exposure. Is presumptive treatment justifiable given the high false positivity, and would the rapid test change the course of clinical care? And if we're awaiting lab results anyway, what would be the added value of the rapid syphilis test, since cost is far greater than would be the case for conventional testing? So I think in a lot of the marketing materials and for the public health pricing that Trinity Biotech is offering, I see a lot about the $10 cost per test. In terms of the quality control sets, those sets are really a marginal cost. We were provided a ratio of 10 kits per one set of controls by Trinity Biotech, so that's what we ended up ordering. When we reached out to our community-based organizations, we asked that they estimate the number of tests that they thought they could use in a year, and some of them were basing their estimations on the count of HIV tests among MSMs. Based on these counts, we wanted to be sure that they would have sufficient additional cassettes to adhere to the manufacturer's guidelines for running quality control. So at $10 per cassette, this can add up significantly to the cost of testing. And there are many test counselors. They're going to various outreach settings, so also adding to the necessity for routine quality controls to be run. So we added an additional 33% to our order to accommodate for controls. But as testing really gets underway, we'll have a better idea if that was an appropriate metric. So we're estimating the actual cost of tests to be about $13. So in terms of the cost of service provision, our HIV prevention staff did an analysis of actual costs for HIV testing across the state, and the statewide average was $96 per HIV test. And this is inclusive of staff time, operating costs, and supplies. I do want to note, however, that the cost is highly variant by site, so the range is quite large. The rapid syphilis test cost is only for the test kit and controls, so it would exclude any staff time, operating costs, or ancillary supplies. And as we began conceptualizing how the rapid syphilis test would integrate, we developed a workflow to set a process for CBOs to test and link the positive patients to the local health department, also taking into consideration the possibilities for a newly identified co-infection of HIV and syphilis. So I know this is very tiny, but Charlie has the PDF, and I believe it's going to be going up on the website. So I'd like to highlight the role of the CBO and the DIS in the process. So the role of the CBO. A surveillance record search is intended to mitigate the expenditure of staff resources if the patient is not a good historian of their syphilis history, but we haven't yet had an instance where we've come back with a positive search result. The EPI-1 is Virginia's morbidity reporting form, and the rapid syphilis test, or RST assessment form, I will touch on both of those shortly. We've asked that the morbidity report be sent to the local health department and our office such that we are able to closely track these cases. And CBOs were provided with a statewide DIS directory to allow them to be able to contact the appropriate person. So if a DIS is available, so if this is during work hours and they're able to get in contact with a DIS over at the health department, it's obviously highly dependent upon location around the state, with more urban areas having greater resources than those more dispersed. And our ideal situation would be that there could be a warm handoff to the DIS. Since the DIS will need to interview a syphilis-positive patient, our goal is not to duplicate the need for patients to list partners and be interviewed twice. If the DIS is not available and the patient is newly co-infected, we ask that CBOs follow their typical protocol. Some CBOs complete the interview and partner elicitation for HIV-positive patients themselves rather than the local health department DIS doing so. If the HIV test was run and it's negative, but the rapid syphilis test is positive and a DIS is not immediately available, then there providing the patient with information to visit the local health department clinic. So I'm going to touch on some of the resources that we put together as we rolled out testing for the CBOs. We developed a QA manual that includes counseling messages since our HIV testers may not be as familiar with syphilis. Also, the EPI-1 that I referenced previously, the goal was to not develop additional paper forms and to use existing documents as frequently as we were possible. So while, and I know that we've had some questions about it on this call already, so while it's not a case-defining test, we are using it as if it was a test that was reportable. So we did have internal discussion about whether or not using the EPI-1 would be permissible, but our final decision was that it is a test for a reportable condition, and therefore we could use the morbidity reporting form for the rapid syphilis test. So as part of the testing program, we asked for certain demographic and behavioral characteristics of patients tested and said that we would be able to receive them in any format most convenient for the CBO. So we weren't going to require any kind of specific form to be filled out, but we did want to know about risk history and demographics. Our HIV testing sites, however, are accustomed to an HIV CTR form, or the HIV counseling, testing, and referral form, and asked for a form that they could use in reporting the negatives, which is on the next slide. As to the testing agreement, the rapid syphilis testing agreement, or some might term it a consent form, this again was at the request of sites. The agreement is still being drafted. However, we have used it as an opportunity to provide greater information about the test and to inform the client that the rapid test is not confirmation of syphilis, but the need for further laboratory testing and clinical evaluation. So I don't have that ready to share, but it's under development right now. So this was the rapid syphilis test assessment form that we put together. I did want to emphasize that it's optional. If we can get that information in any kind of format, right now we have an XLS log that we're getting from one of our sites, completely okay. So long as we get the information, it didn't matter what kind of format it came in. So in terms of the reporting process, positives are reported immediately, but we're having them report negatives on a monthly basis. So if they are sending those assessment forms in, we're having them send in monthly, or the log via fax monthly as well. So I'm only going to speak about our results pretty briefly. Our first test was run right before Thanksgiving in November of 2015. And these are just through the month of January, and we did a major training on the 13th of January. So again, really preliminary results. But we have run 80 tests to date. We have a 21% positivity with 17 positive tests. In terms of our positive, we're still awaiting serologic results on 10, but we have confirmed 4 early cases, but also 3 false positives. And our early cases had titers as high as 1 to 512, and 3 reported a recent history of symptoms. So lessons learned from our pilot testing. So this was a single site that was testing in November and December before we rolled it out to 9 additional CBOs across the state in January. So in terms of recall of syphilis history, we had one patient, not included on the slides previously, who upon further questioning once the rapid test was positive, we believe he had syphilis many years ago. And then it seems intuitive to be comfortable with test use and interpretation before beginning testing, but since positivity has been high, and this was really highlighted when our first ever rapid syphilis test run through this program was positive, so they went back and really provided more training to their HIV testing staff. So the paradigm for HIV testing is leakage to care, and that is frequently what's happening with this rapid syphilis testing program, but the question is really if we can support that. So the costs for CBO staff time are currently being supported in large part by our HIV testing colleagues. But if this positivity remains high, this appears to be labor intensive, and there's a question of whether or not that's sustainable. And then due to patient confidentiality, there's typically no feedback loop to a CBO about the outcome of a case. However, in our discussions, it seemed really important to ensure that CBOs could have confidence in their testing procedures, such that if a client came back and said they didn't have syphilis, they would know that we would be proactively notifying them about the false positive. So our rationale in being able to close this feedback loop was really that by telling them that they had a false positive, we're actually providing them with less information than they already knew. So what they thought was a syphilis positive patient is actually syphilis negative. Therefore, we decided it would be permissible to close this feedback loop for the CBO. So more lessons learned. Our local health departments don't all use the state lab for syphilis testing, and therefore the testing algorithm varies by lab. Our state public health lab uses a traditional algorithm and only will reflex to a TPPA if the RPR is reactive. For this testing program, we definitely need a TPPA, and so we're still working out this process to ensure that when the patient presents to the local health department, a TPPA is included on the order form for lab testing. And I think while we have had false positives, and I think that that's echoed with many of the other presenters, we had an instance where a CBO was screening at a ball, and they had a positive with a palmar rash, and the partner of the positive reporting a history of syphilis and treatment, but was also having new symptoms. So it was an opportunity to link both of those to care, which may have not otherwise happened. So the rash would go away, but he had not otherwise sought care for it. So they were both linked over to the health department for treatment. So in terms of the future for this, at present, we made a one-time bulk order of tests in late 2015. That was when we asked our HIV testing sites to estimate how many they thought they could use. And I think continuation of the program will depend on the program effectiveness. Does the high potential for false positives jeopardize the utility of the test? And I think that there's a cost to false positives for the client in awaiting lab-based test results. We're testing in a generally high-risk population, so a syphilis diagnosis may not be earth-shattering as it would be in a lower-risk setting, but it's worth being mindful of. And so I just want to reiterate that we have run 80 tests of our 6,800 that we ordered, so there's much more to come. Here's our contact information, and I also want to recognize our colleagues in HIV testing here at VDH, and also the policy and procedural documentation from Florida and Pennsylvania, which was repeated in many of our documents, but it was super helpful to get us started. All right, Charlie.
Great, Ashley. Really appreciate the presentation. Again, we really appreciate the work all the presenters have done. To do presentations, there's a lot of work of preparation, and I think it's really helpful to all the participants for the work you've done. So a couple of minutes for questions for either Ashley or anybody else. While we're waiting for questions, there's been a couple. One is, this is for you, Ashley. What's the rate of positivity rate and the number of, syphilis cases in Northern Virginia? If you know it.
Yeah, so we actually do not have any, there has not been any run to my knowledge through the end of January at the CBO in Northern Virginia. So okay. Our data that we're reporting on were tests out of the Roanoke area, Richmond, and Tidewater, Norfolk area.
Was anybody able to use HIV funds or carryover funds to purchase rapid syphilis test kits?
Hold on a second, Charlie.
All right, so this is for any, any of the other speakers too. I think
For
Stevens are addressed.
For our Texas HIV prevention providers, they were able to identify funding through salary savings and other funding resources.
So you were able to use some HIV funds then?
Yes.
Great.
In Virginia, we use carry forward funds at the end of the year.
To purchase the rapid syphilis test kit?
Correct.
Okay. Other questions for Ashley or any of our other speakers before we move on? Okay, well, again, we really appreciate all the other speakers. Couple of quick things. Let us know if you need technical assistance. So yes, no, or if you're not in the program, just say not applicable. But we're curious to see how many people need some technical assistance regarding rapid syphilis testing, and maybe we can do some follow-up work. So let's kind of see where we're at. So it looks like about a quarter of the people on the call, do need some work, and I think we might be able to. If you do need some technical assistance, I'm next going to be able to give you some suggestions of where you can get some technical assistance. First of all, again, we are going to make these slides available, and with these email addresses, feel free to contact any of the speakers, and they can share their experience and refer you to somebody that might be able to help you. Or contact NCSD, and we can, maybe put you in touch with somebody. As always, your CDC program consultant should be able to hopefully provide some technical assistance or link you up with somebody. So talk to your program consultant or Bruce Heath, who can link you up. And then I think regarding NCSD, I think if there's some issues related, obviously programmatic stuff, you can refer it to me or Jessica when she gets on. If you have issues related to legislation or regulations regarding who can do the test or those kinds of things, our state policy and legislative team, Lucy and Rebecca, should be able to help out. Again, if you need technical assistance regarding adolescent sexual health, Sarah Stahlberg, and PrEP and special populations, as well as rapid testing and those special populations, Stephen Hicks can help you out. So I think there's a number of sources for technical assistance. So one of the things, we want some immediate feedback, and we will be sending out a survey with a few more questions, but let us know if you thought this, it's your call on rapid syphilis testing was useful. So it's either very useful, somewhat useful, or not useful. So it looks like about 90% of people thought that it was either very useful or somewhat useful. So I think that's very encouraging to us and our speakers that we hopefully met a need. And again, this is just the beginning. We are, again, we have our website where we're collecting tools, and we really encourage all of you who have developed tools to share. Please share them with them so that we can really make this available to all the different programs. To really save people a lot of time from working, as well as learning from what you sort of learned. Any other questions before we sort of sign off? Again, if you think of something afterwards, feel free to email me or one of the speakers, and we'll address your questions. I think we have so many people on the line, I think it's probably not going to be possible to unmute the phones and have a discussion. We really want to thank everybody for participating, taking your time, as well as for our speakers for all the work in this. And if you do have any suggestions for other topics you would like NCSD to do on It's Your Call, please email me or someone else, and we will, these meetings are for you to help you to enhance your program's efforts. And again, we really want to thank everybody, and good afternoon.